Good afternoon. Today we are going to see the rectovaginal fistula. These vesicovaginal fistula and rectovaginal fistula are the commonly asked questions during in examination, and otherwise they will ask what is genital tract fistula, and that then essay likewise question they can ask, and also essay also like what is defined vesicovaginal fistula, then how we can diagnose that one, what are the management, likewise also they can ask. And here rectovaginal fistula also same likewise they may ask. Okay, afterwards we can discuss about the question paper, discuss in question paper. Then it is the abnormal communication between rectum and the vagina. Recto means rectovaginal. From the word itself we can say rectum and the vagina. The abnormal communication with involuntary escape of flatulence air feces into the vagina, resulting in fecal incontinence, socially disabling conditions. Then etiology, congenital and acquired. Congenital, incomplete portion of the cloa. Then acquired means obstetrical, incomplete healing and disruption of primary repaired or unrepaired recent complete perineal tear. Common cause, obstructed labor, difficult forceps delivery, midline episiotomy, instrumental injury during destructive operations. Destructive operations means if the dead baby is in the intrauterine, in the intrauterus, then we can say we will be cut down the baby's parts and taking the baby outside. That in detail you will study later. What is destructive operation, what are the types, so just only for information I told destructive operations, that is the instrumental injury during destructive operations. Then develop immediately or 7 to 10 days after delivery. In gynecological, following incomplete healing or repair of old CPT, that is perineal tear. Complete perineal tear is CPT, that is we are healing or repairing. Then operative injury, in operations like perineorrhaphy, repair of endothelial, posterior colpotomy to drain the pelvic abscess, vaginal reconstructive surgery. Accidental trauma, fall on a sharp pointed object, malignancy of vagina, cervix or bowel, radiation, infections, LGV, then tuberculosis, inflammatory bowel diseases, Crohn's disease of lower bowel and rectum, then diverticulitis of sigmoid colon, then leads to abscess formation, a burst into vagina. In evaluation, clinical presentation, involuntary escape of flatulence and or feces into the vagina. In fistula is small, incontinence of flatulence and loose stool only, but not of hard stool. Foul smelling vaginal discharge with periodic uncontrolled escape of gas, appear immediately or 7 to 10 days after delivery. Then rectovaginal examination, identification of fistula, number, site and size, assessment of surrounding tissue of fistula, contraction of puborectalis muscle and external anal sphincter should be assessed, perineal body is examined. Then confirmation, how we can confirm that is the rectovaginal fistula. Thin probe is passed through the vagina, from the vagina through the fistulous tract into the rectum or anal canal. Methylene blue dye test. Then air bubble seen in saline filled vagina after insertion of air into rectum through Foley's catheter. Examination under anesthesia. In investigations, barium enema, gastrogafin enema, barium meal, barium follow through, sigmoidoscopy and proctoscopy with biopsy, CT scans, MRI, ultrasound. Then classification based on anatomical location of vaginal opening, that is the low vaginal opening near the posterior fourchette, mid from the level of cervix to just superior to the posterior fourchette. Then high, the fistula is in the area of posterior fornix. Then simple versus complex. Simple are small, less than 2.5 centimeter. low due to trauma or infection, complex or large, high due to IBD. Then radiation, malignancy. Treatment: preventive, good intranatal care, identification of perineal tear and effective repair, identification of rectal injury during surgeries and effective and appropriate surgery, affinity surgery, root transvaginal, transanal and abdominal approaches, determining the factors, cause of the fistula, its location and accessibility, and the status of the anal sphincter. Fistula located in the lower part of the anal canal leads to transvaginal route of the lithotomy position. Fistula located high up in the apex of vagina leads to abdominal approach. Timing: wait 8 to 12 weeks before surgical intervention to allow surrounding inflammation to resolve completely. Then preoperative mechanical bowel preparation. On morning of operation, tap water enema until it is clear. Low rectovaginal fistula repair technique. Then small rectovaginal fistula with. This is the techniques you may read and find out. Can see the positions. That is the small rectovaginal fistula with the proposed line of the incision we had done. Then here proposed line incision about the rectum. Here we are doing here you see the line. Then mobilization of the posterior vaginal wall of the anterior rectal wall. That is be mobilized, comes out towards outwards, and anterior wall of the rectum. You see it comes all full outwards. Mobilized, that is then excision of the fistulous tract. Then after that extramucosal placement of sutures in wall of the anterior anal canal. Then extramucosal second layer closure in the muscularis of the rectum, inverting initial extramucosal suture in line. Can see. Then extramucosal placement with the three delayed absorbed sutures. Two layer closure of the anterior rectal wall. Then the lower portion of the puborectal muscles and external anal sphincter are approximated at third layer. You can see the picture. Then fistula converted to fourth degree perineal tear. Fistula is so close to the external anal sphincter that the closure is difficult. Then this the first part, you see the posterior vaginal wall, inner fistula opening, bridge of the skin sphincter and perineal bodies is divided. Then 2. Excision of the fistulous tract, mobilization of the posterior vaginal wall from the anterior anal canal, converting RVF into fourth degree perineal tear. The 2-layer reconstruction of anal canal, initial layer approximating the mucosal of anal canal, second layer approximating the retracted end of the IAS, inverting into the initial layer. Then rest anastomosis of the retracted internal anal canal sphincter in end of the fashion for surgeons, and reconstructed perineal body. Okay. Then thoughtful preoperative work with extensive preoperative counseling regarding the expectations and the possible outcomes is crucial for the ultimate satisfaction of the patient. Mechanical bowel preparation, perioperative antibiotic prophylaxis and attention to postoperative diet, stool consistency management are important. And rectovaginal fistula repair requires through surgical planning, careful attention to detail and meticulous operative technique to provide the patient with the optimal results. Rectovaginal fistula repair requires careful attention to the sharp decision, gentle tissue handling, wide mobilization, meticulous hemostasis and tension-free closure. Okay, thank you.